So this is the hemorrhage control Monterey County EMS educational presentation for TXA. I'm Dr. Burley. I'm the medical director for the EMS agency. A little bit about the goals and objectives of this presentation. At the end of the presentation, participants will be able to name 3 physiologic steps of hemostasis, describe the pathophysiology of acute traumatic coagulopathy, describe the 4 steps of hemorrhage control according to Monterey County EMS protocol, and describe the indications, contraindications, and dosage for TXA administration in Monterey County. There'll be a post-test following the presentation that you'll need to take and pass. It's 10 questions, and pretty much all of the answers to those questions will be highlighted in this lecture. So a little bit about some basic pathophysiology. There are essentially 3 steps to achieving hemostasis. The first step involves vascular spasm. So at baseline, when blood vessels are not under the battery of trauma, endothelial cells, which line the inside of the blood vessel, release certain chemicals, namely prostaglandin and nitric oxide, that help to relax the smooth muscles of the blood vessel. During times of trauma, what happens is that other chemicals are released, which cause the smooth muscles to contract, resulting in vascular spasms. So the first step in achieving hemostasis is vascular spasm. The second step is formation of a platelet plug. Essentially, injury of the lining of the vessel exposes the underlying collagen fibers, which are underneath the endothelium of the vessel. So there's subendothelial collagen. Is normally not coming in contact with blood products within the vessel, but if the vessel is injured, then the subendothelial collagen comes in contact with platelets and other substances, and that causes the platelets to release chemicals to make nearby platelets more sticky, and that initiates what's known as a platelet plug formation. So we have vascular spasm, platelet plug formation, and then the third step is coagulation. Essentially what we're getting there is formation of fibrin, and fibrin creates a mesh, almost like a spider web, that traps red blood cells and platelets and helps to form a blood clot and to slow and eventually stop bleeding. So those are the 3 steps to achieving hemostasis. You'll notice that the end product of all this is fibrin, and we'll talk a little bit about that because fibrin is important in coagulation and controlling of hemorrhage. Okay, so this is the clotting cascade, my arch nemesis. I had to study this in high school, college, medical school, residency, and right before this lecture, and still I cannot remember all of these different factors and cofactors and where they go in this clotting cascade, extrinsic pathway versus intrinsic pathway, common pathways, prothrombin, thrombin. These things tend to all muddle together when people are talking about the clotting cascade, and it's hard to necessarily tease out what's important because most likely at the end of this lecture, and certainly 3 or 6 months later, you won't remember all the specifics of this cascade, but I want to highlight the things that are important. Specifically, fibrin is at the end of the clotting cascade, and fibrin goes on to form a fibrin clot. And this is very important, again, in the control of hemorrhage in the setting of trauma. Why is fibrin important and what does it do? Well, it creates a mesh which traps red blood cells and acts like a scaffolding for platelets to adhere to as you begin to form a clot. So it's creating a mesh for things to stick to. A little bit about two of the factors that we noticed in the clotting cascade, which are plasminogen and plasmin. I'm going to just go back and again highlight the clotting cascade here with the end product being fibrin and formation of a fibrin clot. Plasminogen and plasmin are important in breaking down fibrin. So plasmin is what's known as a fibrinolytic. It breaks down fibrin. Remember, fibrin's important in forming that meshwork. And so if we're starting to break down that meshwork, that can potentially increase bleeding and inhibit the body's ability to form blood clots. So the way I like to think about plasmin is like a construction worker breaking down fibrin. This is an easy way for me to remember it. So this guy's in there, he's trying to break up that meshwork and ultimately inhibit the body's ability to form clots. Plasmin doesn't normally travel around by itself inside the bloodstream. Essentially, it travels around as something called plasminogen. Plasminogen is soluble within the bloodstream, whereas plasmin is not. And so in a normal, healthy blood vessel, you don't see a lot of plasmin, but you do see a fair amount of plasminogen. And when the blood vessel is injured, plasminogen becomes converted to plasmin so that it can start to dissolve blood clots. So here's our plasmin kicking out a blood clot. There's something called acute traumatic coagulopathy, and we call that ATC. With acute traumatic coagulopathy, what we're finding is an imbalance in the equilibrium of clotting factors, anticoagulant factors, platelets, endothelium, and fibrinolysis. So normally it's a delicate dance between clotting and degradation of clot products, because we can't have the entire body go into systemic clotting. That's something that can contribute to strokes, heart attacks, and other bad things. And so we have, even in the setting of trauma, where we want to encourage clotting at the site of the traumatic injury, if we start to lose balance, bad things can happen. ATC can occur immediately after massive trauma in a setting of shock, hypoperfusion, and vascular damage. Hypothermia and acidosis can make coagulopathy much worse. And unfortunately, hypothermia and acidosis often accompany trauma. And it's these multifactorial processes that lead to decreased clot strength, something called autoheparinization, and hyperfibrinolysis. In other words, the lysis or the breakdown of fibrin, we're doing a lot of that. And so this is a situation in which you can have worsening bleeding through something called acute traumatic coagulopathy. A little bit more about ATC. Again, ATC can lead to uncontrolled hemorrhage. It's just a flesh wound. Fibrinolysis is the most prominent feature of ATC. Breakdown of fibrin is the most prominent feature of ATC. You may see that again later. The significant risk factors for life-threatening coagulopathy include the following: hypothermia, particularly a body temperature less than 34 degrees Celsius, metabolic acidosis with a pH of less than 7.1, a high injury severity score greater than 25, hypotension, specifically a systolic blood pressure less than 70, and all these things can combine to form what's known as the lethal triad. Anytime something is named a lethal something, you know that can't be good. And this is a triad of hypothermia, metabolic acidosis, and progressive coagulopathy. That's known as the lethal triad. How often does it occur? Well, it can occur in 25 to 35% of trauma cases, which is a lot. How does it affect mortality? It greatly increases mortality, 3 to 4 times higher mortality rates in the setting of ATC, and 8 times higher mortality rates over the course of 24 hours. So patients with ATC are at much higher risk of dying from their injuries. These patients tend to require more blood transfusions. They end up with longer stays in the hospital and intensive care unit. They're on a mechanical ventilator for longer periods of time. And there's a greater incidence of multi-organ dysfunction, which oftentimes will lead to death. So these patients can be very, very sick. So why are we discussing all this? What does it matter, all this background? And the reason is you remember our friend, the clotting cascade, right? You have the coagulation cascade that ends up forming thrombin, and thrombin can form, can combine with fibrinogen to form the fibrin that is important in development of that scaffolding to start to trap red blood cells and platelets and assist with clot formation. So this is sort of the basic tendency that the body wants to perform when faced with trauma. And we talked about how plasminogen is a soluble form of plasmin that rides around in the bloodstream and minds its own business until it encounters an injury to the endothelium, in which case plasminogen is converted to plasmin, and plasmin works against fibrin. It tries to undo that scaffolding and inhibit clot formation. We don't want that in the setting of acute trauma. So where TXA comes in is TXA inhibits the conversion of plasminogen to plasmin, and it also inhibits the action of plasmin on fibrin. It tells a guy with a jackhammer, hey, hold up a second, fibrin's doing its job, we need that blood clot formation, let's leave him be. And so that's the action of TXA. There are 4 steps of hemorrhage control. These are some basic steps of hemorrhage control. The first is to apply direct pressure. Exposing the wound, locating the source of the most active bleeding, and applying direct pressure quickly and with enough force to stop the bleeding. Holding direct pressure for a period of time, at least 3 to 5 minutes if possible, longer if you can, and then reassessing, seeing how the bleeding is going, if you've achieved appropriate cessation of bleeding and good hemorrhage control or not. Applying pressure bandaging to continue direct pressure. If you need your hands to do other things like starting an IV or transporting the patient, then applying a pressure dressing to continue the direct pressure that you've already applied manually. And again, reassessing. So you're constantly reassessing bleeding. Have you achieved good bleeding control or not? Do you need to move on to the next stage? If you've achieved really good bleeding control, then you may not need to do these other things. But if direct pressure fails to control bleeding, then there's other things we can do to help encouraging cessation of bleeding. 1, packing the wound with hemostatic gauze directly into the site of the most active bleeding. You may end up having to use multiple gauze rolls. Applying a tourniquet for uncontrolled bleeding to an extremity. You're applying a tourniquet about 2 to 3 inches proximal to the wound. Don't apply the tourniquet over the joint. If you need to apply it at the level of the joint, you can apply it above. Tighten until bleeding stops and distal pulses are eliminated. And then if bleeding is not controlled, a second tourniquet may be applied proximal to the first tourniquet. Document the time the tourniquet was placed and the presence or absence of distal pulses. This is very important, especially when the patient gets to the emergency department. And then if all of that fails to control bleeding and the patient's hypotensive, we can administer TXA. So how do we administer TXA? TXA, again, is this lysine analog that works to inhibit the formation of plasmin. And plasmin, as we know, is a molecule that's responsible for the breakdown of fibrin and clot degradation. TXA is not new. It's been around for decades. It has multiple medical applications, including all of these. But in the setting of trauma, we're using it to control poorly controlled or uncontrolled hemorrhage. How does it work? Again, it inhibits the conversion of plasminogen to plasmin. It reduces fibrinolysis and clot breakdown, and it stabilizes clot formation. What are some of the possible adverse effects of TXA? Well, because it has a tendency to encourage blood clots and allow the clotting cascade to continue, there's a possibility that you could develop blood clots. So thromboembolism, such as DVT or pulmonary embolism, is one potential adverse effect. Patients can sometimes experience GI symptoms, nausea, vomiting, diarrhea. Headaches have been reported, fatigue. If you need TXA, fatigue may be the least of your worries. Dizziness, visual disturbance. So different potential adverse effects. Probably thromboembolism is one of the most significant. Again, this is just reviewing the mechanism of action. TXA inhibits the formation of plasmin and the breakdown of fibrin. And here are the indications for use in Monterey County. Number one, blunt or penetrating traumatic injury with signs and symptoms of hemorrhagic shock and the systolic blood pressure less than 90 millimeters of mercury. Or significant non-traumatic hemorrhage with signs and symptoms of hemorrhagic shock and a systolic blood pressure of less than or equal to 90 millimeters of mercury. So it can be used in both a traumatic setting and a medical setting. There are some exclusion criteria that are important to know. Patients younger than 15 years of age should not receive this medication. Time is important. So what the studies have shown, and we'll go over some of the data, is that TXA is effective if given within 3 hours of the time of injury or the initiation of bleeding. So if the time since injury or the start of hemorrhage is greater than 3 hours, the risks start increasing and the benefits decrease. So one exclusion criteria is time of injury or start of hemorrhage greater than 3 hours. Which, by the way, makes it very relevant for EMS, right? Because we're seeing patients as early as possible during the course of their illness or injury, and if we're going to get this potentially life-saving medication on board, it's important to do it early. Another exclusion criteria is isolated traumatic brain injury, a history of a thromboembolic event, such as a stroke or heart attack or PE within the last 24 hours, hypotension that's secondary to suspected cervical cord injury with motor deficits or signs of spinal shock. So if we think that this is neurogenic shock and they're hypotensive because of neurogenic shock, TXA wouldn't be appropriate because we're giving it for hemorrhagic shock. History of recent GI bleeding or patient with active GI bleeding, and a patient in cardiac arrest. So these are the TXA exclusion criteria. How is it delivered? Well, TXA is administered in 2 doses, generally. The first dose is given in the field. It's given either IV or IO as a bolus. 1 gram of TXA mixed in 100 milliliters of normal saline administered over the course of 10 minutes. So not a true bolus in which you're pushing it in over a few seconds, but you're mixing it in 100 milliliters of normal saline and administering it over the course of 10 minutes. Usually, a second dose is administered in the hospital, 1 gram over the course of 8 hours. So this is the recommended administration for TXA. What are some precautions to be aware of for TXA? Well, TXA should not be administered through the same line as blood products. TXA should not be given as a rapid IV push over the course of a few seconds. TXA should be stored appropriately at somewhere between 59 to 86 degrees Fahrenheit. And there's been shown to have increased thrombotic side effects if TXA is given beyond the 3-hour window since time of injury or initiation of hemorrhage. Talk briefly about the study that helped bring this to the forefront of medical care for trauma. This is the CRASH-2 trial. The purpose of the trial was to determine the effect of early administration of TXA on death and transfusion requirements in bleeding trauma patients. They looked at 274 hospitals in 40 countries, very large trial, and they looked at 20,211 adult trauma patients with or at risk of significant bleeding who were within an 8-hour window from the time of injury. The primary outcome that they looked at was death in the hospital within 4 weeks of injury. And the inclusion criteria were clinical and did not depend on the results of lab testing. So what were the results? First, they took these 20,000 patients and they randomly assigned them to either receive TXA or to receive a placebo. And what they found was that all-cause mortality was significantly reduced with TXA. And the risk of death due to bleeding was also significantly reduced. What they did find is that treatment given after 3 hours increased the risk of death due to bleeding. Hence the 3-hour window that we have for TXA administration. And the conclusions that were drawn from the CRASH-2 trial were that early administration of TXA safely reduces the risk of death in bleeding trauma patients and is also highly cost-effective. This is not an expensive medication. So something we can do to decrease the risk of death by several percentage points in these super sick patients. And the second conclusion was that treatment beyond 3 hours of injury is unlikely to be effective and may potentially be deleterious. This is the Monterey County protocol, T6 for hemorrhage control. It's on our website and will be rolling out with TXA administration at the turn of the year, January 1. And with that, I'll go ahead and end the presentation, but certainly encourage any questions or comments.
I have a question from Chris.
Okay.
He says, is there clinical evidence to support giving TXA with lactated ringers over normal saline? Asking with regards to the lethal triad you mentioned.
So as far as I'm aware, there's no specific evaluation of ringers versus normal saline and whether ringers would be more beneficial in the setting of TXA administration. Good question. Any other questions? Okay, well, certainly if any come up, feel free to contact us here at the EMS agency. Thank you again for listening to this tutorial, and please take a moment to answer the post-test questions. And again, if you have any questions or concerns or would like to dialogue with the EMS agency, we're always available and look forward to further dialogue. Okay. Thanks again. I hope you all have a great day. Be safe out there, and thanks for everything that you do.